Okay, so we're going to talk about, of course, the topic is API, and we're going to talk about overview of API and mental health issues in API, and what are the resources available in our wonderful city, in our wonderful county. So, okay, so let's just see what API stands for. You all know API stands for Asian American Pacific Islanders. A lot of time people forget the Pacific Islander part, right? Because they just think about Asian American, not the Pacific Islander part. So the population, API is about 7.5% of the total population in the country, which is a significant population if you think about it. 7.5% of 332 million is a significant population. And the reason it's important is that this is not one set of population. This is multiple set of people. This is about, if you think about 50 ethnic group, 50 ethnic group is a lot, because this is not one set of people. This is a different group of people, different countries. And these people speak different languages. So 50 ethnic group, over 100 languages. So not only one language, it's 100 languages. Even if you think about Chinese, there are different languages in China. If you think about India, there are different languages in India. So multiple languages, multiple ethnicities. Why that is important? That is important because ethnicities, similarities change when languages change. Your preferences change when languages change. Your food change when your languages change, which means that it is not easy to assimilate because of all those things. So we are talking about a group of people in the country, which are about 25 million Americans. And we talked about how many are there in Houston or so, but about that many people. So, of course, these are people who at some point came to the country. And at this time, some of them have assimilated and some of them are still assimilating, right? What would be the challenges? We'll talk about that. But what do you all think would be the challenges they are facing? Any guesses? Huh? Language is the biggest challenge, yes. Culture, yeah. Different system. Insurance, yeah.
Where would they go when they're sick?
Where would they go when they're sick? Yeah. Mm-hmm. So all these are, of course, challenges. Then the other challenges are that where they came from, systems are different, which is somebody mentioned, and here they are different. Religion can be a challenge. Food sometimes can be a challenge. There are multiple challenges they face. So, of course, when you think about mental health, all these things play a part in your mental health also. And mental health has stigma, even in this culture, but if you're coming from a different culture, the stigma is multiplied into multiple things. Even the name mental health has stigma in it, because when you use the word mental, stigma is there. So stigma is there, and you multiply the stigma in this community. So further go on, what is mental health? If you just think about the definition of mental health includes our emotional, psychological, and social well-being. It basically affects how we think, we feel, and we act. So it basically encompasses everything we do. How you think, you feel, you act, every single thing you do. And sometimes people don't pay attention to it. You go to a hospital, you have chest pain, they will attend to you, they will take care of you, whether you have insurance or not. But if you have any mental health issue, they may let you go because it's not visible. We know that as a psychiatrist, that happens a lot. Also, stress precipitates anything. Of course, it precipitates mental health also. And mental health can be affected in every stage of life, including early childhood. When does mental health issues start in life? How early? How late? Yeah, in the womb. But half of the mental health issues start, or 1/3 of the mental health issues start very early, and we'll talk about that in a second. So there are about 200 plus classified mental health diseases, and some of them are listed here. We have anxiety disorder, depressive disorder, mood disorder, psychotic disorder, personality disorder, cognitive disorders, eating disorders. So which one of this is the most severe if you think about it? Anxiety, okay. Which one is the most commonest? Okay. The most commonest is anxiety disorder. About 35 to 40% of the population suffer from anxiety disorder. Then, of course, mood disorders are the second commonest, but anxiety disorder is the number one commonest. If you think about suicide, about 10 to 20% of suicide is due to mood disorders. 10% because of personality, 10% because of psychosis or schizophrenia, but anxiety disorder is the number one commonest. Have you ever heard the terminology serious mental illness or SMI? What is SMI? And for the purpose of definition, what do we, or not we, but the government considers serious mental illness? What illnesses are considered of this group as serious mental illness? Schizophrenia, one, okay. That's schizophrenia, psychosis, any kind of psychosis, okay. What else? MDD, depression, okay. Mood disorders, fine. No, they don't consider that as serious mental illness, unfortunately. They don't even talk about personality disorder. They think it's perfectly fine to have personality disorder. Although we as a psychiatrist feel that personality disorder patients, when they come, we like to actually run away from the office. Truly. But if you talk to a psychiatrist, but or a mental health professional. But for the purpose of definition, serious mental disorders are schizophrenia, schizoaffective, bipolar, or major depression severe. That's it. PTSD is not serious mental disorder. Obsessive compulsive disorder is not serious mental disorder. Personality disorder is definitely not serious mental disorder to them. The reason I mention that is that it's really very difficult to even imagine. I'll just give you an example. I had a patient, and the reason I mentioned that is this patient was an Asian American person, and he had severe OCD to the point that he will come to see me, and his obsession was that he had to park his car in between the two white lines. Now, it seems like a very minor OCD, but no, he had to park, then he will get out of the car, get a measuring tape, and measure that his car is 5 inches or 6 inches on both sides. Can you imagine how difficult it would be to do that? It will take him over an hour at times to do that. And he could not easily qualify for disability just because of that, because they would not consider this a serious mental illness. Or another patient who has personality disorder, who would swallow razor blades all the time, would not qualify for disability because it's personality disorder. It is not schizophrenia, or it is not schizoaffective, or it is not bipolar, or it is not depression, because these are not considered serious mental illness. That is just the way things are. So just a brief idea of those things. Now, okay, 1/3 of all the mental illnesses start before the age 14, 1/3. 2/3 or half of them start before the age 18, and 2/3 start before the age 25. Why that is important? If you think about it, everything is starting early. Everything is starting early, which means we have to pay attention to kids, right? We have to pay attention, or we have to put all our resources in schools or in colleges or at that level, right? So 1/3 start before the age 14, half start before the age 18, and 2/3 start before the age 25. So everything is starting early. And if we don't pay attention, the problem is there. And a lot of time we miss the warning signs, and they get worse and worse and worse. So that is the key, that we have to pay attention there. And this is where the API population suffers the most. Why? Because in the API population, the recognition of these symptoms is lesser than in the other population, because in the API population, sometimes it is thought that, oh, this is normal, that's okay, maybe they will get better, or they ignore it, or they don't go to the doctor. And that's where we need to educate everybody, but even more so the RP population, that if that happens, please go and see a professional and get some help. Okay. Substance of abuse. Another myth is that a lot of people belonging to RP population, and I can give example of Pakistanis or even Indians, which belong to RP population, believe that, oh, our kids cannot use substances. That's not true. That is not true. Kids are kids, or our people cannot use substances. That is also a myth. Anybody can use substances. It doesn't, substance use, it has no boundaries. Anybody can use substances. Any RP population or any population and any religion person can use substances. So this myth that, oh, that person or this person may or may not use substances is a myth. Which substance is the most common in our area, in Houston, Harris County area? Substance of abuse. Okay, alcohol, anything else? Cannabis, okay. Vaping, okay. Caffeine, okay. You don't cut my morning coffee, please. I know. I'm not saying it's not, but don't cut my morning coffee. Okay. Okay. Anything else? Opiates, okay. Luckily, opiates is less in our area as opposed to the Northeast and all of that. So it's a little bit better for us. As the whole country, alcohol and cannabis is everywhere. So is here. So that's definitely there. Other than that, if you think about the drugs or substances, Houston is famous. I work in the ER. I work in Bentop ER. What we see the most is cocaine. Cocaine is number one in our area. Crack, cocaine, whatever kind, but cocaine is the number one after alcohol and marijuana. We also see meth. We also see PCP, surprisingly, but cocaine is third after alcohol and marijuana. If you talk about kids, vaping has become extremely common. I think it's almost replacing, or maybe have replaced, marijuana in schools because it's easy access. It is the gatekeeper drug right now, and people are not thinking straight that what to do about that. Another thing which is coming very often is the hookah bars and all. That's also very common. And it has a lot of side effects, but we can go on and on. But it's also common in RP population. All these things are common in RP population. All these things are there. Drugs are related to area. So for example, if you go to Lubbock, Texas, or countryside, what would be common other than alcohol, marijuana? They will cook meth. So that will be there. If you go to New York, what will be common? Heroin. If you go to California, what will be common? They like to fly high. So LSD. Ecstasy, exactly. Right. So things are common based on the area. Okay, so let's just talk about overview of the mental health issues in RP population. So we'll talk about all of them one by one. So the issues will be the cultural identity issue, stigma and shame, barriers to mental health, language barriers, insufficient health insurance, somebody mentioned on this side, immigration status, faith and spirituality, alternatives to treatment, and all the others. So let's just talk about them one by one. So start with the cultural identity issue. Now we're talking about a lot of second generation RP population people, and cultural identity is an issue. They're facing cultural identity issue. They're trying to balance their family ties, and they're trying to see what they can do and how they can assimilate with the American society, because of course they are in America. This is not that easy for everybody, because imagine coming from another culture, another society. At home, you may be preached another culture, and you are here seeing another culture. So of course you are in a cultural identity. You may be taught different things at home, that these are the principles. You go outside, there are different principles. So it is different. What do you do to keep a balance? And I think the responsibility lies on us. I'm RP, member in that sense. Also, a lot of responsibility lies on the seniors also, to help the second generation assimilate. Because in some ways, so what can we do as a senior member of the family? What can we do to help our second generation for this cultural identity? Any answers? Nobody has an answer?
Listen to them.
Good, sure. Listen to them. Yeah. But also, we need to have a little bit lesser expectation from them. We need to be less strict with them. We need to try to come with a compromise situation with them, because we are the one who chose to come to this wonderful city or this country. When we chose to come to this country, we have to understand that there has to be some level of assimilation. You have to accept some of the cultural norms here. You may incorporate some of your cultural norms, but may not be able to incorporate all of your cultural norms. So there has to be some compromise, and you have to accept that. Some of us are not able to accept that, which causes all these cultural identity issues. So this understanding needs to happen. The earlier it happens, the better it is. Otherwise, it causes a problem. And it is a learning process. Some people learn a little bit harder way. And some kids, especially when it doesn't happen, really become severely depressed to the point of being suicidal. So this needs to happen earlier than not. The second, if you think about, is stigma and shame. So stigma and shame is extremely important. As I said before, mental health is associated with stigma even in anybody, of course. But the stigma and shame is going to be more in the API population. Why? Because we have this notion that we can't be sick, we can't have a mental health problem because we cannot tell anybody, we cannot tell our neighbors, we cannot tell our family, we cannot tell our brother, sister, anybody, nobody, because there's some shame associated with that. There's some weakness associated with that. If somebody has depression, people feel that there's something bad about it, because that's how a lot of us grow, that any mental illness is something bad. Whereas if you have diabetes or hypertension or asthma, it's fine, but mental illness may not be. So because of that, people hide. When people hide, they don't seek treatment. So that shame and stigma is a barrier to seek treatment. And it's more in API population. It's here also, but it's much more in API population. What is the solution to that? One solution to that is to talk about that in your faith places, whether it is a temple or a mosque or church or whichever is the place of worship, to talk about that so that people come up and people are open about that. So that's one solution about that. Next is, if you think about it, what is the barrier to mental health? So if you think about it, only 20% of Asian adults with mental illness, this is according to a survey, seek treatment in 2020. And these disparities were worse because that's how they got poor treatment. But why did they not seek treatment? Language was one, finances were other, and again, the stigma and shame all were combined. But they didn't seek treatment. So seeking treatment was an issue for API population, which caused poorer outcome in every single aspect. Now, if you keep going on further thing, language barriers. Of course, a lot of us want to see a physician. I notice a lot that people say, if you are an Indian descent, I would like to see an Indian physician. If I'm a Vietnamese descent, I would like to see a Vietnamese physician. If I'm a Chinese descent, I would like to see a Chinese physician, because people feel comfortable going to that physician. Maybe because of language, maybe we feel that they know our culture more. Same thing applies for mental health, maybe even more so, because they feel that they will understand the cultural norms more so. We don't have a lot of therapists or psychiatrists who speak those languages. We talked about 100 languages, 50 ethnic ethnicities. We don't have a lot. We have some, but we don't have a lot. And that causes another barrier. Imagine talking to somebody through an interpreter line is not the same as talking to somebody who knows your language. So that causes another barrier. And that's another issue. And that's a problem in older generation, even more so than younger generation, because a lot of API population over 65 does not speak the language, which becomes a significant problem. So that's another barrier to seeking treatment. Healthcare coverage. Healthcare coverage is a problem, and actually it's a bigger problem in the Pacific Islander group than the other group. And If you don't have coverage, of course, you're not going to seek treatment. And we'll touch on the coverage part a little bit more a bit later. But healthcare coverage is a problem because you need to have healthcare coverage to seek help. And while Affordable Care Act has helped with the mental health coverage because it takes care of the pre-existing problem, but still, healthcare coverage is an issue. You need to have coverage to get care. And a lot of RP population don't have healthcare coverage. So that's the other issue. So talking about healthcare coverage, we are here in Harris County, we are in Houston. How do you get care if you don't have insurance? Any ideas? So if you don't have any money, how do you get care? Go to Hope Clinic. Great. Okay. So that's the reason I'm right. I have this here. So there is something called federal poverty. Yeah, so there's something called federal poverty level. So federal poverty level is different for every state. For the state of Texas, for one person, it is 14,580. It changes every year based on inflation and all of that. So it's 14,580. If you're one person and you make less than 14,580, you can get free services at multiple places. So for example, you can get free services at Harris Center. You can qualify for free services at multiple other places. Harris Health, somebody mentioned Harris Health. Harris Health would provide you free services if you make up to 150% of federal poverty, which will be around 21,000. So it's a little bit more than Harris Center. They will provide you free care for up to 150% of federal poverty level. If you're two people, you add another close to 5,000. 3, another 5,000, 4, another 5,000. You keep adding close to 5,000. The exact amount is written there. So that is how you get free care. Harris Center will provide you up to 100% of federal poverty level, Harris Health up to 150, and certain other entities will do the sliding scale. So we have a lot of entities which will give you care without anything if you don't make money. So you have options to get care. So it's not that you cannot get care. Our city is blessed with many other options, and I'll share some other options too. So you have options to get care. So that's one. Now, Affordable Care Act helped a lot of things. Not only that it took care of pre-existing condition, you can have your kids covered till 26. So that's a big thing. And that was very good. About 16 plus million people are insured with Affordable Care Act. Before Affordable Care Act, we had about 256 million insured. Now we have about 300 million people insured in the country, which is pretty good, actually. Out of the 332 million, 300 million people are insured, which is actually a pretty good number than what it used to be. Now, somebody mentioned, Texas. Texas is definitely not in the best shape, but hopefully it will get better someday. 5.2 million people are still uninsured, which is about 18%. And Harris County is the worst, even more than 18%, about 22%. Fort Bend County is a little bit better. I live in Fort Bend County, so I'm a little bit happier in that sense, but Harris County is not that good. Okay, Medicaid. How easy it is to get Medicaid in Texas? It's not. It is actually not at all easy to get. I think you have to make less than maybe 5,000, 4,000 a year or something like that to get Medicaid. It's like really low. I don't even know how you survive in that much money, perhaps. But it's like really very low to get Medicaid, with the exception that if you are a kid, you can get CHIPS or Medicaid, yes. Or you're pregnant, you can get Medicaid for 13 months or so. Or if you're on dialysis, you can get Medicare or so. But otherwise, getting Medicaid in Texas is not easy at all. So that is the reason you need other programs like Harris Health or other FQHCs and others. But getting Medicaid in Texas is almost next to impossible, with the exception if you're a child or pregnant or others. But not everybody can be pregnant or need to be pregnant. Okay, so immigration status, a lot of time immigration status is a barrier to seeking mental health care. So for example, you tell a person who's depressed, we tell them, why don't you go to Harris Health or Harris Center to get help? They are scared that they are undocumented. They don't want to go because they feel that if they go, somebody will talk about their immigration status and they may not get help, or they may be deported or whatever. And usually that's not the case. We don't do that. That's not our job to do it. But they are worried about that. So that's the reason they may not get help. So that causes a barrier in terms of getting help. And you cannot blame them because that is a barrier, although that's not our job. We are not police. Faith and spirituality plays a big role in terms of help also. A lot of times people feel that mental health is a punishment, or bad mental health is a punishment. It is a bad karma because of something they did. It is a punishment of sin they did or something like that. So they don't seek help. They just feel it is a punishment already and they just take it as is. So they just ignore seeking help because of that. So that happens too. Then a lot of times API population will seek alternatives to care, which could be anything. It could be traditional Chinese health or acupuncture or spiritual healing or Tai Chi or anything, folk medicine or anything. But that will delay in going and getting the regular care. So the delay will cause worsening of the symptoms, which is not a good thing, and that's going to cause a problem. But that is common, and those things do happen. Somebody mentioned about suicide. Suicide is the second leading cause of death between the ages of 10 to 14 and 24 to 34. 988 is one of the best things which happened about 1.5 years ago, 16th of July. So thank you very much for that. And there's one death about every 11 minutes. People talk about suicide, but to me, it's absolutely important to talk about suicide, but even more so, it is important to talk about suicide survivors. Why? Because there are about over 1 million people, about 5 million people who think about suicide, about 1 million people who try to commit suicide. And the number one predictor of suicide is previous suicide. And we can save those people from a future suicide. And the way to save them is to get them help. And if we can save one life, I think you have done an enormous job. So we all need to think about those people who have tried to commit suicide in their lifetime. And if you can try to help them and save them from future suicide, you have done a lot of work. So please always think about that also if you see anybody who's depressed, who's tried to commit suicide or anything like that. So that's extremely, extremely important because that is a very, very important thing. So there is another myth. People feel that, okay, what is your sense about API population and suicide? Is suicide more in API population or less? I'm not going to go to the next slide because it will give you the answer. So, more, okay. This side says more, this side says less. Okay, more, less, more, okay. You may have to move to this side. Okay. So the myth is that Asian Americans have higher suicide rates, but the fact is suicide rates for Asian Americans is half that of national rate. There's a slight exception. Muslims, which also some of them are, of course, in API population. There was a study published in August of 2021, which showed that was suicidal thoughts, not completed suicide. The first statement is suicide rate, which means completed suicide. Okay, so let's just go to the second and then I'll mention that. The second myth is Asian Americans have higher suicide rates than other racial ethnic groups. In fact, Asian American college students have higher rates of suicidal thoughts. So thoughts are more, not the completed, but the thoughts are more in college students. Just keep the thoughts in your mind. There was a study published in August 2021, which showed that Muslims in US have twice as likely to have suicidal thoughts in this country than non-Muslims. Thoughts. So college students, API, more suicidal thoughts. Muslims, more suicidal thoughts. So we are talking about overall Muslims, not API, but overall Muslim. But there are a lot of APIs included in that population also. So there are a lot of Muslims, but interestingly, Middle Easterns, how are they qualified when you think about the census? Do you know? they are considered whites. So they're not in the API population. Middle Easterns are considered white in terms of population. But right now they are, yeah. So they will be included as, okay, when will that change?
I'm not sure when.
Okay, but yeah, so in the last one, in 2021, it was, yeah, so they were not. And the third myth is, if you see, young Asian American women have higher suicide rates of racial, ethnic, and the fact is American Indian Native women have higher suicide rates. So that was the fact. So if the simple question is, does our API population have a higher suicide rate? The answer is no. So the answer for that was no. Okay, but thoughts in college students, yes. Thoughts in Muslims overall, yes. So those were yes. Okay, any questions so far? No? Okay. Okay, so what are the current mental health resources? Somebody mentioned Harris Health. We have Harris Health. Harris Health has 2 hospitals, Bentop Hospital, LBJ Hospital. We have about 23, 24 clinics. If you qualify, meaning if you make less than 150% of federal poverty level, which is around 20,000 for one person. If you have 2 people, you add close to 5,000 on top of that, you qualify for services. We also take people with insurance. So you can come and see a psychiatrist, therapist there. That's one. You can go to Harris Center. They have multiple clinics also. They will see you free if you qualify for their free services, but you have to make less than 100% of federal poverty level. Then you have UT Physicians. You have VA, but you have to be a veteran to go to VA. You have federally qualified healthcare agencies. A lot of them are listed here. You have Ibn Sina. They do low cost. Of course, you have Hope Clinic, which is also listed here. The number one census-wise, the number one in terms of census, the number one mental health population is unfortunately is in Harris County Jail. It used to be 9,000. Now they have about 5,500, 6,000, unfortunately, which is a lot. It has decreased from 9,000 to about 5,500 or so, but it's still a lot. But they are there, unfortunately. Okay. In this city, if somebody wants to see a psychiatrist, there are a lot of psychiatrists, psychologists, therapists who will see you without insurance. Most of them, or a lot of them, will see you without insurance with cash, which is a barrier to care because not everybody or a lot of people can afford that. That is a problem also. So what are the challenges? So the challenges are access for people. And by access, I don't necessarily mean access, I mean early access. Why? Because if you're depressed today, you need to see somebody in a few days, right? You don't need to see somebody 2 months later because that appointment is going to be as useless in my mind as not, because by that time, either a person will be in the emergency room or maybe better or have seen somebody else, or God forbid, something can happen. So early access is the key because I always compare it with chest pain, that if you have chest pain, you don't want to go and see the doctor that late. So early access is the key, just not access is the key, it's early access. Crisis intervention emergency room. How many psychiatric emergency room we have in this city? 3? Okay, I wish we do. Beverly, where's the third one? Please tell me. Herman doesn't have a psychiatric emergency room. So where are the psychiatric emergency rooms? Bentop, yes. No, LBJ does not have a psychiatric emergency room. UT doesn't have a psychiatric emergency room. We're going back to Bentop, but okay. Bentop is one. And then there is a freestanding psychiatric emergency room, which is walking distance next to Bentop, NPC, which is the psychiatric ER of Harris Center. When they go on diversion, they put a sign, just like she's showing me the sign that I have 5 minutes. They put a sign saying, go to the nearest emergency room, which is Bentop. So their patients come to us all the time. So we have 2 emergency rooms, both next to each other. In a city this big, You need to have one emergency room south, one in north, one in east, one in west, not both next to each other, but we have two only, right? So anybody who's going to help me with another psychiatric emergency room? We have people here who can help. Okay. Inpatient beds, pediatric beds, there is a lack of inpatient and pediatric beds for people who do not have insurance. People who have insurance, we have beds. We have money, yes. Drug and alcohol treatment, of course, is a big issue. It's not easy, especially if you don't have insurance. Gun violence is another issue. And lastly, which is my biggest challenge, especially if you work in the psych ER, is the Senate Bill 359, which is, I've worked in many states. Perhaps this is the only state in which, as a psychiatrist, if you see a patient in your clinic or in ER, as a psychiatrist, patient comes and sees you and patient says, I want to shoot myself and I want to go home and shoot my family because I feel that I'm possessed by devil. Psychiatrists cannot hold the patient until the judge signs. In every single state, the psychiatrist can hold the patient and sign for up to 72 hours. In this state, psychiatrist has to wait for the judge to sign. This is the only state. And the judge may take 4 hours.
Other state the same law.
Which state?
I've been practicing Missouri for more than 50 years. You can sign the 96-hour hold, but until it is approved by the judge.
So Arkansas was not the same. Delaware was not the same. New York was not the same, but maybe Missouri also. But Texas is like that also. So there are some states then, maybe more than Texas. Yeah. So that causes a problem because the patient can literally go and hurt themselves, and there's a problem. So we tried to rectify that, but it just didn't happen. So anyway. In that case, what? No, you can break the confidentiality. You can call the police, but by the time the police comes, patient may be gone and patient can hurt.
You cannot hold it till the judge makes the decisions?
Not allowed. Legally not allowed. No, legally not allowed. That's what I'm trying to say. That's what I'm trying to say. You don't have legal power to hold in this state. No. Legally, look, you cannot hold. Anyway, so I'm going to stop here and we have a few minutes for question answers. Thank you. Any questions? Yes.
It makes me think about, I know you wouldn't want to do this, but mental health, a mental health warrant. And since you can't do a psychiatric hold,
right?
Could you do something like that?
We do mental health hold, yeah. But that takes time because that is valid when the judge signs, which is usually 4 hours or so. So, of course, we go that route, but it is only valid after the judge signs. So, yeah. So if you ask the security, they're going to say, we cannot hold until it is signed by the judge. So.
You cover a lot of grounds and made us think a lot about like cross-cultural healthcare.
Sure.
But I'm interested in like cross-national healthcare. I wonder if for patients of yours, especially like first generation, if they've like received care overseas or they're concurrently receiving care in multiple countries, what are some of the challenges that come up for you?
There are many challenges, especially if they are from different countries. First of all, they cannot even accept that there is an insurance system. They're not used to that. That's new for them. If you think about even HIPAA, that's new for them. They're not used to that. So different challenges in different countries, depends on which country they're coming from. Some countries do have some things, some countries don't. So it just depends on which country, but it's a very generic question. But again, depending on which country they're coming from. They're coming from Europe, the challenges would be different. If they're coming from South Asian countries, challenges would be very different.
So not so much
no, that would be that too. But yeah, we deal with immigrants also or refugees also. Their challenges will be completely different, which I didn't cover. So she's telling me to shut down, but thank you. Okay, we started 2 minutes late, so we have 2 minutes.
Yeah, right.
Yeah.
Are you seeing trends amongst older AAPI adults on more reported mental health crises or suicide attempts or completed suicide? What are the trends in that area?
Yeah, so we are seeing about among older, not the suicide trend necessarily, but more actually psychosis is getting a little bit more common. We're seeing that bipolar is or mania or so, but not necessarily the suicide, not necessarily suicide.
One more question.
So is there evidence of therapy effectiveness received from mother tongue speaker versus English or foreign language tongue speaker or therapist?
There is some evidence about that, and the evidence is though related to the understanding of the therapy. For example, if you're doing DBT or CBT, a lot of time through the interpreter, they don't understand the aspect of therapy. They don't understand the real principles of therapy because the interpreter may not be able to explain therapy. Now, some interpreter may be good at explain, but the therapist may not even know what they're explaining. How do you know what they're telling them? So there is evidence that if you know, then you can explain in the right way and you know their response also. Whereas when you filter through a person, everything can slightly change. So there is some evidence there.
But in terms of receiving the message, like the way you connect the message in our language versus.
Yes, that's what I'm saying, that there is evidence that if the person speaks their language, there is evidence that that's more effective. So,
One more.
yeah.
This is the last.
Last, okay.
So can you elaborate just a little bit about the no hold 72-hour and where that comes from? I assume this is legally.
Yeah, so where
legal
that comes
prohibition.
from is that I think when we presented this Senate Bill 359 in 2013, the House passed it, the Senate passed it, the governor vetoed it, and the worry was that it is a violation of human rights. That was the worry of the governor. Of course, we think that we're trying to, of course, help the patient by doing that, but the worry was it was the violation of human rights. So that's where it was coming from. We tried to do it again this session also, but it didn't go anywhere. The reason I try to mention that is that maybe someday somebody will help. So in other states, you're able to hold the patient, not let the patient leave. So our choices are either we hold the patient and do something against the law and take the risk, and somebody may someday sue you, or if you're that worried, or you let the patient go. In other states, the physician can write. In other states, the physician can write and the patient can be held. Now, in the same state of Texas, if you're thinking about human rights violation, in the same state of Texas, a police officer can hold a patient for up to 48 to 72 hours on a one-page police packet. And that's not a violation of human rights. But a psychiatrist cannot. A police officer can. No comments. So, thank you.
Thank you for your excellent presentation and stimulation of discussion. A lot of these topics will be touched upon in our other sessions. We're going to take a set change, okay, as our next panel comes up with Dr. Varma. As we do, and where's my guys that are going to make the set change? I think we're going to move the podium because we're going to have a panel of 3 clinicians. As we make this, I want to make a few announcements. When we break up into our breakout sessions, this room will be divided into 2 rooms. And this is Community West, and this is Community East. And if you look at your program, the community breakout group will meet down here. I want to say, is this side? Is the other, I did get it wrong? The West, okay? And this is East. Okay, and so let's see. So it will be youth on the 2nd floor in the Chang boardroom. It will be family and domestic issues in the 3rd floor conference room. Community will be in West, 1st floor, and older adults will be in East, down here. Okay, does that, y'all understand what I'm saying? Okay. The other announcements that I wanted to make is after we, and there will be signs and volunteers to help show you around to the groups that you were wanting to go to. After the breakout sessions today, we will return to the 1st floor for a reception. We have some delicious food planned for you. So you want to stay around and network and enjoy the food and visit our vendor booth some more. And then the third announcement I want to make is there is a poster session that's going on the second floor in the Gordon and Sylvia Kwan balcony. So please go by and view the posters when you have the opportunity. Judges will be reviewing the posters and a winner will be announced at about 6:30 to 7. So you'll want to stay around to enjoy the food, mingle with other participants and the speakers. And now I'm going to turn the program over to Dr. Vandana Varma, who will be the moderator and panelist for the next session.